My name is Daniel Chan, and I'm one of the criticalists and nutritionists at the Royal Vet College. So today we're going to be talking about how to get our patients that may be critically ill into the path of recovery and the use of nutrition. So one of the things that's really important to realize is that when our patients are critically ill, there is a lot of changes that occur within the gastrointestinal tract. So one of the things that we know is that gastrointestinal tract is actually one of the most important organ systems, both in health but also in disease states. Unfortunately, during critical illness and injury, the gastrointestinal tract is actually commonly affected and prone to dysfunction. And therefore, we have to pay attention a little bit more about what things that we can do to help patients that have been affected, either with critical illness or injury, that then changes how their intestinal tract works. One of the things that we know as clinicians is that there are lots of different manifestations that actually change how things are uh, affected within the gastrointestinal tract. So, for example, in appetite, nausea, abdominal pain, vomiting, diarrhea, ileus, and therefore abnormal GI function, and even ulcerations are all manifestations of a dysfunctional gastrointestinal tract. And so, one of the things that we really have to be cognizant about is how do we deal with these changes and how we can actually modulate some of these things. So, the reason why we actually see so many of these intestinal problems is that there are actually underlying pathophysiologic processes going on. And it's important to actually make the connection of the actual pathophysiological dysfunction and the clinical manifestation. Because what we deal with on the clinical side of things is the clinical signs, the presentation. What's underlying that is the understanding that there are things happening that's leading to those things. So, for example, increased gut permeability then that changes sort of the uh, signals that the body might be getting from the intestinal tract. With bowel edema, potentially due to injury to the gastrointestinal tract, maybe they're losing a lot of protein, then actually changes the perfusion of the gastrointestinal tract cells. With that, you might actually have also altered GI bacterial flora, and they send signals, and these molecules are actually more permeable. There's even talk about actual bacterial organisms translocating from the inside of the gastrointestinal tract into the bloodstream, but also functionally, in terms of an abnormal GI tract, then what we see is that nutrient assimilation issues where you have impairment, where animals are just not able to absorb or assimilate these nutrients. And part of these processes can be due to both inflammation, oxidative injury, and abnormal GI, intestinal, and immune function. So, knowing that our patients can be affected by all these problems, what can we do as clinicians? Now, one of the things that we rely on is treat symptoms, but also we actually have to understand that we have to treat the underlying condition. And now there's a pathway where we might actually be able to modulate the pathophysiological process as long as we understand what's driving some of these symptoms. And so those are sort of the important things to keep in mind is that although we may be treating symptoms, we actually could also target and condition. Now, one of the things that we see in many critical patients is inappetence. Now, what we do about it might be different depending on what the situation is. Well, one of the warnings I would like to give is that offering different types of food and trying to entice may not be the best way of ensuring nutritional support. And that's because most animals with appetence are refusing to eat, and it's not a lack of food availability that's causing the problem. So approaching patients with trying to entice them is usually not met with a lot of success, because the reason they stopped eating their normal food was not because they suddenly wanted something different. So offering different foods is usually not effective. And we have to think about what is causing the animal not to wanting to eat, and that's what you need to address. Now, I get a lot of questions about the use of appetite stimulants, especially in a situation where animals are coming in for not wanting to eat. And one of the things that I warn you about is that depending on the agent used, you actually may get undesirable effects. So, for example, this dog is actually being given an appetite stimulant, and the dog, instead of eating, is actually sleeping, because many appetite stimulants affect behavior, and a lot of them are actually sedatives. So, diazepam for a while used as an appetite stimulant, cyproheptadine, sometimes they're using cats, and now we're seeing mirtazapine. All of these agents actually affect behavior. They affect neurotransmitters. Some are actually antidepressants, and so it's not uncommon for these appetite stimulants to have serious side effects. So what we know about appetite stimulants is that although they are generally safe, that they're not actually effective in getting animals to consume what they should consume. I do believe that they have a place in managing patients, mostly during the recovery. So once the patient is on the mend, is being transitioned to actually go home, this is where I think appetite stimulants have a role. But I don't think that as patients coming in the clinic is the time where they should be, trialed on appetite stimulants, because that actually delays more effective nutritional support. And so I think that an important sort of lesson is that if we do the nutritional support correctly, then we're able to help them transition to normal voluntary eating. Now, with vomiting and nausea, we do have some medications that we can use in some of these cases. So metoclopramide is very commonly used both in dogs and cats, and they have the drug has many benefits in that it can actually help with not only central control of nausea, but improve GI motility. And if that inappetence is due to um, abnormalities in gut motility, then that can be helpful. Other more direct antiemetics like chlorpromazine, ondansetron, and morapitant are also available, and the response is mixed. So some patients are well controlled with these agents, and some animals are actually resistant to a combination of all three of them. Now, one aspect that we can't emphasize enough is actually pain control, because animals that are experiencing pain are not going to be patients that actually will want to eat. And one of the things that's important to recognize is if a patient pain management is well controlled, they'll be more likely to take on feeding. And in terms of what agents, well, so obviously when you're dealing with critically ill patients, sometimes we have to rely on opioids. And we like opioids because they're very effective, they're reversible, they have a high safety profile. But the one sort of disadvantage is that it can cause ileus and abdominal discomfort in some patients. So sometimes we should transition them to agents that are not as prone to causing these problems. So buprenorphine might be a good option in your acute phase, although the fact that they're not reversible can cause some concerns. Now, butorphanol is a very good sedative analgesic for certain conditions, but they're not very good acute pain. So most critically ill patients are not likely to be well managed with butorphanol, and we need to be appreciative of that. In terms of patients that with absolute severe pain, we might have to think about different strategies. So epidural analgesia, sometimes intra-abdominal analgesia with local anesthetics, and also multimodal analgesia. So this is when we combine different analgesic agents so that we get the lowest possible dose, so that we can reduce their side effects and still synergistically sort of modulate their pain. And then in some critically ill patients, this is the sort of strategy that works with them. In patients with diarrhea, one of our goals is obviously to maintain hydration. And so one of the questions I ask clinicians is, are you accounting for that, what we call sensible fluid loss? Because it's a measurable amount. And so when we think about fluid therapy, we need to account for their needs, their fluid losses in sort of our plan. And so that could be with IV fluids, but also when we feed them, when we think about nutritional support, we can also think in terms of fluid restoration. Now, one of the strategies that we don't think is usually helpful is actually to use GI paralytics, like Imodium, for example, where we actually are perhaps trying to address diarrhea, but probably not in the best way, because what we want to do is normalize GI motility, not stop it. But we also have to think about in patients with diarrhea, whether diet content actually has a part to play. For example, fat content may actually uh, stimulate or trigger diarrhea because the absorption capacity may be compromised. Other things that may affect an animal's ability to tolerate is actually the osmolarity of the solution. So, for example, some people would think that um, a diet that is sort of pre-digested, where we're just feeding sort of the very small molecules would be easier. The problem is the osmolarity of these solutions. They're called monomeric diets, are very hyperosmolar, and what they tend to do is draw water into the gut, which the animal may then develop diarrhea. So a lot of our sort of diets for critically ill patients have been polymeric diets. So that is just not the tiny molecules where it would increase the osmolarity. Other patients actually require fiber. And the way fiber benefits patients is that they modulate the amount of moisture, so water in the gut, and they also help with motility. So it keeps going back to if you can restore GI function, it takes care of most of the clinical signs we're trying to address. Now, there is a disorder that's well recognized in people, which is paralytic ileus, where most of the entire GI tract is actually non-motile. We don't think that occurs very often in dogs, but when it does, it's very difficult to deal with. What we tend to see more often is where there are areas of decreased GI motility. Well, we don't have a good way to capture that, but we can assume that many patients may have decreased GI motility. Things such as abdominal surgery by itself may actually impart GI motility at least for up to 3 days. And so when we have patients that have major abdominal surgery, we shouldn't be surprised if their GI motility is not normal for at least a couple of days. And that has implications about the way we deal with these patients post-operatively, especially in regards to feeding them. Now, in terms of when we do think that we have a GI dysmotility problem, one of the things that we have relied upon is actually using prokinetic agents. So metoclopramide infusions, so 1 to 2 milligrams per kilogram per day, is a very popular way of doing it. If you don't do continuous infusion, you might do sort of more um, titrated approaches where it's giving 3 to 4 times a day, orally or injection, and it might be sort of right before feeding. Now, other agents have been sort of proposed to help with GI motility. So ranitidine, for example, is reported to have a prokinetic effect, but actually unlikely to overcome clinical disease. So animals that actually have true abnormal GI motility don't seem to respond very well with ranitidine alone. So although it has that effect, probably not enough to sort of regulate GI motility in most patients. Now, erythromycin is very interesting. It's normally we use it for as an antimicrobial, but we know that in low dosages, it actually stimulates motilin receptors, which then affect GI motility. Now, the dose is much, much lower than an antimicrobial dose, so only a half to 1 milligram orally every 8 hours. But this hasn't been really evaluated in many patients. So we're still not sure whether this is a good approach. Now, one of the things that we quite worry quite a bit about in animals that have any sort of vomiting is whether or not they have some ulceration. Now, in people that are critically ill, this is a major source of morbidity. And we recognize that it occurs to a certain extent in animals as well. Now, gastroprotectants are probably one of the most prescribed medications for patients with any GI sign. And the combinations that are commonly used include antacids like cimetidine, ranitidine, agents that help coat any erosion, so sucralfate. But in terms of if there's really a suspicion that you have ulceration, the only effective treatment really is actually a proton pump inhibitor, like omeprazole. And that's because the pH of the stomach needs to rise from the normal 1 to 2 to above 4 at least in order for the mucosa to be able to heal properly. So we now have recognized that that might be a better approach if you actually have gastric ulceration. Famotidine, another H2 blocker, is probably the next best thing, although it's not available as injectable in the UK. But in areas where you can get intravenous famotidine, it might be as effective as a proton pump inhibitor. Now, one thing that is actually important is that when you have gastric ulceration, nutrition is not a contraindication. And people worry about that when you feed, you require acid production, and therefore that might make the ulcer worse. But one of the things that's important to recognize is that the number one contributor to ulceration healing is actually a blood supply, so perfusion. And what nutrition does is actually it helps the gut perfuse. So you actually get vasodilation of the gut, and that brings blood supply, and that is the number one way in which the gut's going to heal. Because with improved perfusion, you actually have production of the protective layers, the mucus production, which is very important to protect the mucosa, is dependent upon good perfusion. Food also stimulates motility, and with motility, you get normal hormonal function, and so therefore it contributes to normalization of the gut. Now, when we ask the question, can we do anything about GI dysfunction? And I kind of mentioned about some of the therapies, and one of the important things to think about is how do they respond? Can we say whether they are responding to treatment based on our approach to treat the symptoms? So one of the things that we want to think about is, can we do anything about the integrity of the gut? Because obviously the surface of the epithelium is important because it controls the traffic of nutrients, fluid, electrolytes, and even the various antigens. And if there's any problem with the integrity of the gut, these things are affected. So our approach is really trying to focus on, if we can, in supporting the gastrointestinal integrity. The things that contribute to abnormal gut permeability is actually hypoperfusion, lack of nutrients, the inflammatory response, and also nitric oxide dysregulation, which ties in with perfusion. So nitric oxide is a very important molecular messenger because it also controls the microcirculation. And the gut is very dependent on the microcirculation, not just the major vessels, for perfusion. So if there's anything that compromises the microcirculation, it will have an effect on gut permeability. In terms of the protective functions within the gut, so I mentioned the mucus layer, but also the epithelial barrier, the maintenance of these cellular junctions between cells, and also the immunological defenses. So secretion of IgE, and IgA are important in part of protecting the host from the onslaught of bacterial sort of organisms. And in all of these defenses, are dependent on adequate gut perfusion. So we actually need to make sure that we always think about how we are dealing with perfusion issues in our patients. Now, one of the things that clinically, the only thing that we use is actually peripheral perfusion. So we can check the pulses of our patients, their heart rate, blood pressure. It might give an indication, but that's not a very specific way of looking at the guts. We can't necessarily translate um, these measures of blood pressure, heart rate into gut perfusion, but clinically, there's not much else we can do. There might be some research ways of looking at GI perfusion, so we actually have to accept that we're limited in that regard, and we could focus on sort of global assessment of perfusion. Now, what are the things we can do to help preserve gut integrity? Well, if we wanted to think about the future, it might involve using pharmaconutrition, where we're actually using nutrients to modulate responses. So we mentioned oxidative stress, inflammation. So there might be a way of using certain nutrients to that effect. And one of the most talked about component of micro sort of immunonutrition is glutamine. So glutamine is very important for a number of reasons. And in particular, when we talk about critical illness, when we talk about the GI tract, it's actually because glutamine is a preferred fuel source for a lot of rapidly proliferating cells. So that includes all immune cells, but also the enterocytes. So what we worry about is if the animal is undergoing a disease state where they're not eating, their sort of store of glutamine may not be sufficient. And therefore, those cells that are rapidly dividing, like the gut, like the immune cells, may be prone to more problems. So the concept of actually maybe supplementing glutamine to patients that are critically ill has a lot of sort of good evidence, a good basis for it. Um, there's some discussions about what's the best way to deliver that glutamine. So maybe it's parentally, but enteral nutrition has a role in that as well. So one of the questions is, should we actually be giving glutamine to our patients? Well, there's no side effects that we know of. Although there's no positive veterinary efficacy study available, there is also little, known about what's the optimal dosing. But because there is some positive data out there, experimentally, at least in animals, that it makes sense to consider adding glutamine in whichever way. So feeding a complete diet might satisfy the glutamine need, but it's actually nice to think about other ways where we might actually help the host. With oxidative stress, we know that when we have patients in shock, whether they have infection, trauma, there is sort of a burst of oxidative stress in the animal. And one of the opportunities for nutrition is that you might be able to modulate that response by feeding them antioxidants. So one of the things that, thinking more about, is the content of the diet have a role? There is an opportunity to use antioxidants in sort of the way that we feed our animals. And so vitamin C, vitamin E are commonly mentioned in nutritional therapy, but there are other things as well. So SAM meals, S-adenosine selenium, and acetylcysteine are all potent antioxidants that although we haven't fully evaluated, they may have a role in the way we feed animals. Now, in terms of what is probably the most important way that we can help support gut integrity and support GI function is actually to feed the gut. So enteral nutrition is consistently being shown to improve GI function, and clinically the most effective way to get um, nutrition into critically ill animals is actually to use feeding tubes, because we know that this then allows us to give specific amounts of nutrients. Relying on animals to eat voluntarily when they're ill is very difficult. And so the most effective and proven way to ensure animals get nutrition is actually to use and feeding tubes. So what we also know that even small amounts are beneficial. How small is that amount? That's a harder answer, um, a harder question to answer, but it might be as low as 25% of their energy needs if fed through gut, maybe just enough to have some major benefit to the animal. In terms of which are the most common ways of feeding animals with feeding tubes. So nasopharyngeal and esophagostomy feeding tubes are becoming more common, and I think that those are very good options, especially because they're easy to implement. Gastrostomy and jejunostomy tubes are more specialist type of methods. But I think the good news is that most practices can actually use nasopharyngeal and esophagostomy feeding tubes, and therefore we can address the needs of a great number of cases. In terms of what do you do if the animal actually is still not quite ready? So I get asked a lot about animals that vomit after they've been fed. And so one of the strategies that we kind of promote is that if you have a feeding tube, instead of giving bolus feeding, where you have, let's say, a 10 to 20 ml per kilogram volume, you actually might do it continuously at a very slow rate. So anywhere from half a mil to 2 mils per kilogram per hour may be tolerated in many patients. Now, if the patient has obvious continued dysfunction, so they're persistently vomiting, they have severe diarrhea post-feeding, and they might have what we call gastric residual volume. So the accumulation of fluid within the GI tract, particularly in the stomach, that may lead them to regurgitate, to be uncomfortable. Well, one of the things that we might be thinking about is maybe our strategy needs to be adjusted. So because patients have various degrees of GI dysfunction, so some animals are not ready yet to be fed these complete diets. So what we can do is obviously try to address perfusion issues to make sure that the gut integrity and motility issues are addressed as best we can. But maybe we can think about the composition actually of what we're feeding them. And and a complete recovery liquid diet may not be the best first step in some of these patients. So this is where the concept of micro-enteronutrition comes up. So as the ability to fully digest food may be compromised in patients, initial approach to feeding critical patients could be using sort of diets that require minimal digestion. And so many believe that using solutions that are basically fluid, electrolytes with some sugars and amino acids might be best step forward because it's starting to prime the GI tract to help restore its normal function so that it can tolerate more complete diets. So when micro nutrition solutions, um, the benefit may come actually from the effects on restoring GI function more than providing substrate for energy. And so that's a pretty important concept that we're not trying to meet energy or nutrient needs. We're trying to get the gut back into a state where it can tolerate feeding. So I think the expectation shouldn't be that micronutrition should be used to meet all the nutritional needs because that's really not its main purpose. What we're trying to get is animals ready to tolerate sort of the best um, nutrient composition diet. So it might be useful to think about transitioning them from no feeding to micro-ento feeding to then full nutritional support. So the advantage of using this approach is that it's easily absorbed. The gut does not actually need a lot to absorb fluid or electrolytes, and the combination of electrolytes with sugars is quite easy to achieve. And some believe that amino acids in that mix actually helps restore GI function better. So when we actually eat a complete diet, we rely on surface enzyme systems. So if there's significant GI dysfunction or injury where there's loss of surface cells, so this is again going back to the integrity of the gut barrier. If we're actually losing cells, maybe they're being sloughed as a result of hypoperfusion, then those mechanisms by which we absorb many nutrients are compromised. And therefore, delivering nutrients in an electrolyte and sugar solution might be the best first step. The other important thing is that most of these sort of solutions, or microentry solutions, are low in fat because fat does a couple of things. It requires digestive enzymes, so pancreatic secretions to help digest and assimilate fats, but also there's also